I'm delighted to be here today to talk to you about prevention of osteoporosis and about bone health in general. It's one of the reasons I went into endocrinology was that this is a field where there is a lot of opportunity for prevention. So let's get started. As many of you know, bone is very important. It's a living, remodeling, and growing tissue. It provides a strong and flexible support for your body. It protects your internal organs like your heart and your brain. It serves as an anchor for your muscles. And something that a lot of people don't think about is that it's also a reservoir for important electrolytes in our body. So 99% of our body's calcium is stored in the bone, taken out into the bloodstream when we need it. And we need it for a lot of things, muscle and brain, for instance. Phosphorus reservoir, sodium. There's emerging evidence that glucose is also stored in our bones. So this is an image I want to spend a little bit of time discussing with you. This graphic portrays what happens to bone mass over a woman's lifetime, but it's similar for men with the ages being a little bit different. And the key concept is that you can think of bone mass sort of like a bone bank account of bone. And the window of opportunity to really gain a lot of bone mass and achieve your peak bone mass occurs when women and men are in childhood and up through the teenage years. So usually peak bone mass is achieved by age 25 through a variety of reasons. Hormones play a big role in this, like estrogen, testosterone, growth hormone, and so that's why an endocrinologist ends up taking care of bone health. A lot of people ask me, why does a hormone doctor take care of bones? So you make a lot of deposits and accrual up till about age 25. From 25 till about the 40s, some people can stay pretty stable. After that, particularly around the perimenopausal transition, the withdrawals from this bank account really begin to outpace the deposits. You're still making deposits, but the balance has swung in favor of the withdrawals now. So it's a lot like the money that we also make during our working years and then after retirement. So here, can I get the point? So it's what I have on the x-axis is age, and then bone density on the y-axis. And so as you can see here in the 20s and 30s, bone remains pretty in a good range, the green zone. And then it takes a nosedive around the perimenopausal transition when estrogen goes away. And at its most rapid, so this is right around the early menopause, folks can lose up to 5% of bone a year. That does slow down after a while, but it's a pretty dramatic number. I mean, that's analogous to what astronauts lose when they go up for a space mission. For men, it's a little bit different. There isn't a 5% per year time, but it starts a little bit later in men's life, but it also is a Mother Nature's relentless way of taking out deposits. And this pink zone represents the osteoporotic zone. So let me tell you about osteoporosis. It's a medical condition, or some people might call it a life phase, where one's bones are fragile and breakable. So with minimal trauma, meaning like closing a hatched door or getting a hug, one could break bones. Important bones include spine, wrist, hip. So operationally, if someone has had a low trauma or a fragility fracture, that qualifies as osteoporosis, regardless of what your bone mass is, because something is not so good with your bones. For those who have not yet had a fragility fracture, the way we screen or determine who's at risk is with the T-score, which is what I've tried to show you here. So T-scores represent standard deviations away from a healthy mean. So the mean would be the 50th percentile, and where you see this number 0 here. So, and the person who's 0, the 50th percentile median bone mass, is a 30-year-old woman. So compared to a 30-year-old woman, somebody who has a T-score of -1 is about the 16th percentile. And so anybody less than -1 is osteopenia. We call that a risk, intermediate risk group. And then anybody who's 2.5 standard deviations worse than the 30-year-old woman has what we would call osteoporosis. So very porotic bone, more likely to break, and you can see that fits into the first percentile for a 30-year-old woman. This curve would look very different if I plotted somebody who's 65 against her 65-year-old counterparts, but for the purposes of knowing who's at risk for fracture, it's compared to the 30-year-old woman. This slide just wants to show you that fractures, the fragility fractures, are a problem as we age. With each passing decade, it becomes more likely that one would fracture. And so these are per year of 1,000 people, men and women, how many are going to be fracturing? Again, it's per 1,000, so we're talking, 2%, 4% kind of range. The red line indicates hip fractures in men and women, and the blue line represents fragility fractures of important sites. Not that any, all bones are important, but these particular ones are hip, spine, wrist, and upper arm. So the take-home messages here would be that, yes, for women, it tends to be a little bit more dramatic, but for everyone in the 70s, 80s, that's when that rate really picks up. So here are some risk factors for osteoporosis, since we're talking about prevention, and this is going to help me get into that portion of the talk. I've divided it into modifiable and non-modifiable. Of course, there is some room for argument here about what's modifiable versus non, but rough list here. So poor nutrition, sedentary lifestyle, a low body weight, smoking of any amount, alcohol greater than 3 drinks a day, early estrogen or testosterone deficiency. Sometimes this is for a medical reason. Sometimes, somebody had to have their ovaries removed. Sometimes it's not. Someone who's prone to falls, and then culprit medications. And in that category, we usually think about steroids like prednisone, Medrol dose pack that people could take for asthma, and a whole variety of other things, and the aromatase inhibitors used for breast cancer treatment. There are other ones on that list as well. Non-modifiable, advancing age, being female, Caucasian or Asian, having a family history. So if your mother had a hip fracture, that really increases your risk of having a hip fracture. And then culprit medical conditions. This is a big, long list. So it includes things that are associated with inflammation, rheumatoid arthritis, lupus, things where somebody would be on steroids a long time, like a solid organ transplant. Lactose intolerance is on this list as well, too. And then hormonal imbalances, excess thyroid hormone, excess parathyroid hormone, for instance. Bunch of other things I haven't met. Malabsorption, celiac, sprue, inflammatory bowel diseases. So now moving on to the part about how are we going to preserve the bone, how are we going to preserve the bone mass we get, how do we make that bank account last for as long as we can before we slip into the pink zone. So first thing is start now, maximize your bone bank account, and then do excellent nutrition. And each of these bullet points I'm going to go into more detail in the next few slides. Be physically active. You've heard this message from all the previous speakers, and including Dr. Stefanik's introduction at the beginning. Maintain a healthy weight, and again, same thing, same theme. A good weight that's not both in excess or underweight either. Pay attention to menstrual patterns. I have an interesting slide that I'll show you about this later. This is for our premenopausal women. And then prevent falls. So the first thing everybody wants to talk about is nutrition, and calcium's obviously first on that list. So here I have the Institute of Medicine's guidelines for what is the recommended daily allowance. There's 3 columns here: estimated average requirement, upper, safe upper limit, but I circled for you what the recommended daily allowance is for most of us. And it's portioned out by ages. So for our premenopausal women, and men, it's oftentimes in the 1,000 milligrams a day range. Postmenopausal, we recommend 1,200 milligrams. And this is including diet. So if you get some by diet, you don't have to take extra supplements. Supplements are purely that. They're supplements to get you to that goal of 1,200 milligrams. You'll notice that for pregnant and lactating women, the recommended amount can be higher as well, too. And what did I say here? Oh, about supplements. So we prefer diet, of course, if you can, but it's hard for some people, particularly those who are sensitive to dairy. And if you are going to take supplements, your body, your stomach can only absorb about 600 milligrams at a time. So we recommend that you take those supplements in divided doses if you're going to need more than 600 milligrams. Here are some food sources of calcium. There are many that you can find on the internet, but here's a good rule of thumb. Dairy is quite rich in calcium and is also pretty bioavailable. Salmon, this is canned and including the bones, has some. Green leafy vegetables also, but you have to be eating them in a big proportion. So let me show you a good rule of thumb for how to find what's the calcium content you're getting. So you can look at the back of your milk carton. Soy milk and almond milk are also these days really good sources of calcium. Fortified breakfast cereals, fortified orange juices, yogurts, and there's a big range depending on the yogurt. So if calcium is listed on the food label, then you can assume that product has it. If it's not listed, you can assume that product doesn't have calcium. So the 30% is referring to the 1,000 milligram number, the premenopausal number. So you just merely add a 0 to that 30% and you get 300 milligrams. So this happens to be from the back of a skim milk bottle. So 8 ounces gives you 300 milligrams. These days there are some fortified milks and fortified almond and soy milks that will get you up to 500 milligrams per 8-ounce glass. Vitamin D will be the next nutrient to pay attention to. So vitamin D has been a hot vitamin, but I can claim it for the bone and muscle world that we've known about vitamin D for a long time. It's being investigated for a whole host of other things, but it certainly has a role in calcium and bone metabolism. So you need vitamin D to prime your intestines and your stomach to absorb the calcium that you take. So you can be doing a good job on calcium, but if you're low on vitamin D, the calcium's going to go right out into the stool. So the sources of vitamin D include sunlight and certain foods. It is pretty difficult to get it from food, so I have a list up there that I'll show you later. And then supplements typically are vitamin D2 and D3, and I've given you the scientific names here. D3 is usually what you'll find in your supermarket, although D2 tends to be one that we've historically given as a prescription. Both work. This is, again, the Institute of Medicine's recommendations on what folks should be getting for vitamin D supplementation. Again, pay attention to the one inside the red circle. It's about 600 to 800 international units for most, premenopausal and postmenopausal. Now, I want to take one moment to tell you a caveat. There are many experts in the field who believe that folks, especially those who are paying attention to their bones, may do better with a little bit higher than this. For instance, 1,000 to 5,000 international units. It's a matter of debate, and it's a matter of giving public health guidelines to people. But if you think you're one of them, it potentially could be true. It's very variable, whereas calcium is pretty much almost one size fits all. Vitamin D, we see a lot of personal variation, and so it's an easy blood test to do just to see if you're on track. There are harms to getting excess, but certain people really need a lot more to keep their stores buffed up. And we go for 30 to 50 nanograms per ml for bone health generally. These are some sources of vitamin D. You'll see, it might have printed out a little bit tiny, but it's not that many things. So mushrooms, sun-dried shiitake mushrooms, sun-dried, I think, did I see sun-dried shiitake? No, that was it. Egg yolk has a very little bit, and that it also tells you how much sun light can give you, but we also don't want to be in the sun for too long. So supplements are usually the easier way to go with vitamin D. This is an emerging concept okay, so we talked about calcium and vitamin D. What about protein? So the recommended daily allowance in America for protein I've shown you here in this blue graph. It's about 0.8 grams per kilogram. A lot of thinkers in the bone field think that one requires even more to maintain good bone, something on the order of 1 gram per kilogram of body weight. And the nutrition field in this has swung pretty widely over the last few years. For a while, they were thinking animal proteins are bad because they make your blood acidic, and that's not so good for bones. But a lot of studies have come out since then, and it seems that protein, including animal protein, at about the 1 gram per kilogram or higher is good and safe for bones. This helps you provide the matrix on which to hang your calcium and things like that, your mineralization. So particularly in those at risk, I also recommend that they pay some attention to the protein they're getting in their diet. So let's move on to physical activity and exercise. I have 2 slides, one for the younger sort of peri-pubertal set, and then one for those who are after puberty. So it's interesting to note that right about 40% of one's peak bone mass, so the best bank account you're going to get happens in the 4 years right around puberty. 2 years before your growth spurt, your height growth spurt, and 2 years after. So it's a really huge window of opportunity. And so for girls right now in America, that's about age 10 to 14. And for boys, it's about 11 to 15 years old. And it's interesting, I have down here some colleagues, names down here who work here at Stanford and see folks in the sports medicine clinic. They propose that there's some data showing that ball sports are perhaps the best at building bones. So for those of you who have kids and grandkids and neighbors who you can recommend things to, it turns out basketball and soccer are particularly good at helping build bone mass. And these are observations, as Dr. Stefanik pointed out, these are observations, not necessarily evidence, but we've noticed that girls and boys who play these sports, maybe because it's cutting and jumping in different ways, fast and slow, they have the best bone density compared to their colleagues, their friends who are doing, for instance, running sports, which is also high impact, but it's going all in one direction. And what's really compelling to me is that if you do these around the time of puberty, it helps you later on in life. So when these athletes turn into elite runners later, for instance, say they come to Stanford and they become a runner, but they were a basketball player in puberty, in the puberty years, they seem to do better with bone health, less stress fractures, better bone density than their teammates who only ran during the junior high years. So it's something interesting that we'll certainly be following. So for those of us who are past puberty, what else can we do? So weight-bearing exercise is still really important, whatever your age, premenopausal, postmenopausal, and I've listed some things that are considered weight-bearing in general. For instance, the classic non-weight-bearing ones would be swimming and cycling, which are great exercises for cardiovascular health and other things, but they're not the best at building bones. So I'm not saying don't do them, but maybe cross-train. Strengthening, so muscle resistance exercises are also very important. So yoga and Pilates play a role here. Balancing is really wonderful and has been shown to protect folks against, protect at least for better bone density. And so that can be just standing on one leg for 3 minutes at a time every day. Tai Chi, posture. And that would be through the physical therapists oftentimes can help a lot with helping align the paraspinal muscles and the core muscles so that our bones are no longer the strongest, don't have to be the strongest thing in your core. And we're aiming here for bone health for 30 minutes a day, every day. And that's pretty much in line with what the other speakers have talked about too. So I want to spend a minute on this slide as well too for those of us who have a hand in our younger kids' health as well too. I told you about the wonderful effects of bone, of exercise on bone, but there is such a thing as too much of a good thing. And this is female athlete triad, a term you've all heard. It's something near and dear to my heart because I take care of a lot of patients with this condition. So it's 3 things as triad. Negative energy balance, so too much exercise, too little caloric intake to fit that. Loss of menses as a consequence, so their body has gone pre-puberty. It's decided it's not time to reproduce. I don't have any energy, so I'm going to lower the estrogen. I'm going to stop having periods. And then as a result of that, low bone mass and a propensity for fractures, stress fractures in particular. This is very reversible and treatable. It's not that once you go in, revert to pre-puberty that you have to stay there with improving the calorie balance. Everything can be fixed, but it can be chronic if not jumped on quickly. Not all infrequent periods equal female athlete triad. There's a whole lot of things, so this is when it's good to get your doctor involved to help ferret out which condition it is. It's tempting to just take a birth control pill and have the periods come back and figure that's the end of it, but that's really masking the problem. So it can help maybe make you feel better in the short term, but I would encourage those to get a handle on what is the underlying menstrual pattern. Birth control pills just give you quote unquote artificial periods, and don't let your body, and giving that kind of estrogen back does not help the bones, interestingly. So risk factors for who are these people likely to get female athlete triad? It's interesting. when Dr. Williams was talking about the folks predisposed to perimenopausal depression, perfectionism, depression, disordered eating, underweight, orange skin from eating too many carrots, it sort of hints at eating disorder, and recurrent slow healing injuries. Preventing falls is another important piece. So this seems like a no-brainer to a lot of people, but sometimes it's helpful to point out good lighting, good shoes, keep rooms clutter-free, certain rugs, we don't want the kind that slip and slide. It's okay to use assistive walking devices, and then take it slow. A lot of my patients who come in with a fracture are bustling around. They forgot something at the last minute, turned around and tripped on, doggy's leash, or it was around Thanksgiving time. They're so excited the kids are coming home, tried to go to too many supermarkets at one time and, weren't paying attention and tripped in an unfamiliar setting. So what are the guidelines for screening if you think you're at risk, or even if you're not at risk? So the U.S. Preventive Services Task Force recommends for women 65 and older, for men maybe around 70 and older, think about it. And for women, if you're younger than 65 but you have those risk factors I told you about before, family history, underweight, problems with your periods in the past, those people are eligible to do it sooner. Yes? Okay. Okay, so we'll go really fast. This is what a screening bone density scan looks like. It's called DEXA, dual X-ray absorptiometry. Here's a picture of a spine and a hip, and this is of a younger woman, so her dot you see there on that scale is still in the good green zone. The femoral neck here, this region right here in the groin, is an area we're particularly concerned about. That's where fragility fractures tend to happen. The leg, the femur, was really built well to withstand forces this way, not so good with aging when it goes this way. So if you're falling, try to fall front or back, but not on your side. And the report just tells you what a T-score is. And so this particular patient has a good T-score at all sites. So, okay, what happens, we talked about prevention, but what happens if, Mother Nature beats you, and she oftentimes does, even with the best of intentions. You get into the osteoporotic zone or you have a fragility fracture. It's good to know there are safe and effective therapies. I know folks may have questions about this later. It's always a controversial topic. But even if you're doing all the best lifestyle, Mother Nature she trumps everything else. So it's not your fault, even if you ate right, exercised right, everything like that. It just happens. People go into the pink zone. And so I'll just put this slide up really quickly. I'm almost towards the end. These are the medications we have available, FDA approved, and then the calcium and vitamin D I put at the top. So it's important, again, to show you about Mother Nature. Calcium and vitamin D are necessary, but not necessarily sufficient. They, statistically don't prove, haven't been shown to prevent hip fractures and other fractures, whereas a lot of our bisphosphonates and other types of therapies here, I put the generic and the brand name, have shown a reduction in fragility fractures. And you can see there's a few differences in some of them. This is a slide I usually give to my colleagues to show. So it's if you're considering therapy, something you might want to take to your physician to discuss. I mainly point out that some are especially good for the hips, whereas others may not have shown evidence there. Other sources for guidance besides your primary care physician would be specialists. I've listed all the different kinds: rheumatologists, endocrinologists, physiatrists, orthopedists. Coaches are very good at this. So I talked about the female athlete triad. So if you're concerned about a young one who's exercising a little bit too hard, that's usually a very good place to turn first. National Osteoporosis Foundation has a great source of exercises and dietary guidelines. And the NIH wing of the NIAMS has also really wonderful information. So this is what we talked about in summary. Bone is living, and it's growing. Peak bone mass by age 25. With osteoporosis, bones break with minimal force. You can preserve it and prevent the ultimate decline with excellent nutrition, weight-bearing exercise, and attention to activity at the pubertal growth spurt. And then if you need to move on to screening, it would be with a bone density exam. Thanks.